Flash radiotherapy, or flash RT as it's known, is a very kind of catchy phrase, but it's also known as ultra-high dose rate radiotherapy. Conventional radiotherapy, as it's done now, is typically given 0.03 or 0.04 gray per second. Flash radiotherapy is given at 40 to 100 gray per second. So instead of a garden hose, it's a little bit like a fire hose in the way the radiation is delivered. Now, studies were done 30 years ago looking at bacteria, and surprisingly showed when these ultra-high dose rates were given to the same total gray or same total dose, the bacteria did fine. But only recently, in the last 6 to 7 years, have folks developed machines that can deliver ultra-high dose radiotherapy to small animals in preclinical studies and larger animals. And it has this very unique phenomenon where it appears to kill tumor cells in the same way that conventional dose rate radiotherapy kills tumor cells, but spares normal tissue. And this has been looked at now in a variety of animals, looking at skin toxicity with hair loss or ulceration. It's been looked at the GI tract in terms of intestinal crypts, in several different preclinical studies. So the idea is, can Flash now be adapted to humans where you achieve the same degree of effectiveness, or even more, because it may be safer, while preserving normal tissue? So that's really the basis of it. And it's, I think, a very exciting potential future for radiotherapy. Sure, well, the preclinical studies have been done in cats, they've been done in mice, rats, mini pigs, again with those very intriguing results with tumor cell kill, but preserving normal tissue. The early clinical trials in humans include a study that was just completed looking at treatment of patients with bone metastases, and the very preliminary results were just presented at a conference in Europe just a few days ago, where the patients seemed to tolerate it quite well. And the hope, again, there is that this can now be adapted to humans, where we may be able to treat cancers. And I'm focusing on breast cancer. Many folks are approaching this in other areas that have been harder to treat, like pancreatic cancer or cancers of the GI tract, where radiation traditionally has been very difficult to use because of the complications. Personally, I see a lot of room for it to help patients who are being treated for breast cancer, just because of the side effects of radiotherapy and why someone don't want radiotherapy, and some of the long-term impacts that the radiotherapy has for women who have breast cancer. Well, I think two things have to happen. First, much of the work has to be done on a preclinical level. There are many things that have to be worked out, including the machines, what kind of machines to use. It can be done with photons, electrons, protons, the doses that are being given, the dose fractionation schedule. These really all have to be worked out. We also have to continue to demonstrate effectiveness, as we did in our preclinical work, showing that we could eradicate small breast cancers. The next step for us is for us to go on and show the safety component of this. And there are many areas within breast cancer, for example, whether it's the things where patients could benefit, such as less breast fibrosis, less fat necrosis in the tissue, lower rates of lymphedema for patients who are getting radiotherapy. I talked just earlier this morning on the impact of radiotherapy on women who are having breast implants and post-mastectomy reconstruction. If these could all be improved, it would be terrific. The equipment still needs to be worked out. There are many sites, well, I shouldn't say many, I would say there are several sites that are really expert in this, because it's so new, working in the United States and also in Europe, to try to advance the machines and find which machines work best and what are the dose fractionation schedules that are best to achieve that same level of effectiveness and prove that safety that we're looking for. We're working on more studies now looking at safety. We're looking at doing not only studies in mice using murine tumors, but we're also looking at using immunodeficient mice that are carrying human tumors to demonstrate, prove that it's also effective in killing human tumors. And then proving safety. We have models that we're trying to develop now that are actually looking at miniature breast implants and implanting these in mice and seeing if we see fewer side effects from flash radiotherapy delivered in mice with miniature implants compared to conventional dose rate radiotherapy. So I think if this works, this will be a tremendous advantage, because so many women who come in looking for breast cancer care, they ask for mastectomies, they want bilateral mastectomies. They've heard from patients who have had side effects that they want to do everything they can to avoid radiotherapy, which is very effective and works quite well. But if we can make it safer, that would be ideal. The only other thing that I would add is that, in the past 20 years, we've seen tremendous advances in radiotherapy. I'm a surgeon, but I see how this can come in and help patients in terms of their local regional management. 20 years ago, we were told 6 weeks of whole breast radiotherapy. We don't need to improve it. That's the best that we can do. And now we have partial breast irradiation, we have hypofractionated radiation, we have fast-forward radiotherapy. So I think there's still room for improvement. And hopefully FLASH will be a major shift in the paradigm of how radiotherapy is delivered for many different tumors, including breast.